Hello, dear doctors. Today we'll discuss how to approach psychiatric cases, and I find those kind of cases most difficult. That's why I will spend slightly more time than usually. Those cases rarely appear on your exam, but if they do so, I want to be ready. So as always, we start here with our differentials, and the three of them will be bipolar, schizoaffective disorder, and drug-induced psychosis. Psychosis. And the common finding for all of them will be hallucinations. That's why we can copy and paste it in all three. There are not many diagnostic studies for such cases, and usually those are urine drug screen, TSH and T4, and CBC electrolytes. Electrolytes. Okay, now we go to our history of present illness. So this is hallucinations. So when you put your findings in support for your diagnosis, you have to use medical terms instead of what patient tells you. That's why instead of hearing voices, we write hallucinations. You can specify as hearing hallucinations. Auditory hallucinations. Okay. Always ask about suicidal and homicidal ideation. So always, if you suspect bipolar disorder, let's say a patient tells you those findings of mania, you always have to ask him about episodes of depression. And of course, screen for hypothyroidism, no change in weight. Skin. Sorry, skin. Review of system is very short. Medication no prescribed or over the counter. And let's say this patient has family history of psychiatric disorder in his mother. This is the most difficult word. Schizophrenia. Sexual history. Partners. So this called with one medical word is called sexual promiscuity. And let's say this patient uses recreational drugs, and you have to specifically ask him what kind of and last intake. Now we go to our physical exam. And this part have to be very detailed. You have to describe patient appearance, his behavior, affect, mood, and this will help you to support your differentials later. Those are all findings for mania. Euphoric. Appearance. Pupils equal, round, react to light, and accommodate. And the most detailed physical have to be mental exam. Alert and oriented. In person and and place. Sorry, place. And disoriented time. And you have to check patient's attention and concentration as well as memory. So please practice those kind of cases 3, 4, or maybe 5 times, because those are most complicated. And now we can fill our differentials with findings from history and physical. Okay. So increased energy will go for bipolar as well as for it's affective due to affective component. Increased. What else? Euphoric mood, of course. Less need for sleep. Episode of depressed mood will go for bipolar. Sexual promiscuity will go for bipolar as well. Promiscuity. And here also. And for drug-induced psychosis, we of course can use information about drug intake. Okay, and one more finding. History of schizophrenia will go for bipolar, and here also. And now findings from physical exam. Just all of them, almost all of them. They are too long, so we'll use different lines. Actually, it can go here also. What else? This will go for first 2, but pupils can be changed in drug-induced psychosis, so we don't put it here. Normal thyroid, which excludes let's better say no tremor, excludes hyperthyroidism, and concentration impairment and short-term memory impairment